Hello everyone. So today we will discuss about obesity. Obesity or adiposity is now going to be a pandemic, worldwide problem, this obesity. If we talk about India, every one in fourth individual, every one out of four individual is either overweight or obese. Yes, this is the data for India. If we look at the 4%, every one out of 4% is either overweight or obese. So, does this overweight and obese means the same thing or it is different? Overweight is defined as a BMI of 25 to 29.9. So, what is the normal BMI? The normal BMI is 18.5 to 22.9. If we look at the Indian cutoff or the Asian cutoff, the normal BMI is 18.5 to 22.9. Yes, it is not from 18.5 up to 24.9. Indian, the cutoff is low. So you may be obese or we may be obese more early than other countries like European countries. So we have lower cutoff because of our genetic material, because of our gene. We are supposed to be not obese. Indian are supposed to be not obese, so the cutoff for Indian is low, 18.5 to 22.9. Otherwise it will lead to major adverse effect in the form of complication of obesity. So we have lower cutoff 18.5 to 22.9. This is the normal BMI for Indians. Normal Indian BMI is 18.5 to 22.9. And what is the normal for WHO? Normal for WHO is 18.5 to 24.9. So what is overweight and what is obese? If the Indian population, we defined overweight as BMI from 22.9 to 24.9. This is the overweight for Indian. If you are in between 22.9 to 24.9, you are overweight. And if you are more than equal to 25, then you are obese as per Indian guideline. So obesity, is it a disease? Yes, it is the root cause of majority of the disease, majority of the cardiovascular disease, majority of the respiratory disease, majority of the metabolic disease, the fatty liver, the diastolic dysfunction, the kidney dysfunction. Everything can be attributed to one and only obesity, adiposity. It is going to be the major pandemic in coming years. Everyone is still, if we talk about the recent data, every one in fourth individual in India is said to be either overweight or obese. So definitely it is a pandemic in India, and it is related to majority of the adverse effect, majority of the complication associated with obesity, the cardiovascular complication, the liver problem, in the liver, the problem in the heart, problem in the brain, kidney, everywhere, metabolic dysfunction, metabolic syndrome, everything we attribute it to obesity nowadays. So it is a concern that you know about obesity, the treatment of obesity, the prevention of obesity. It is a multidisciplinary approach, and the obesity per se is multifactorial in origin. It is not caused by just eating. If you think that if we eat more food we become obese, but it is not true. It can be defined by endocrine mechanism. Endocrine dysfunction can lead to obesity. It can define by neurohumoral dysfunction. Set point is in the hypothalamus, satiety center, the appetite center in the hypothalamus. So there are central regulation of obesity from the hypothalamus, special neuron present in the hypothalamus which regulate the appetite, which regulate the satiety. Not only the central mechanism, but the peripheral mechanism also plays a important role in obesity. The peripheral adipocyte or the fat cell, adipose cell, certain hormones are produced, certain molecules are produced from those adipocyte or the fat cell, which can imbalance the weight of the patient, which can lead to obesity. We will discuss everything. So it is a multifactorial disease. Obesity is a multifactorial in origin, and it is characterized by excessive body fat or adipocyte accumulation that will impair the health. It will lead to cardiovascular disease, it will lead to hepatic dysfunction, it will lead to kidney dysfunction, it can also cause brain dysfunction, it can also cause respiratory problem like obstructive sleep apnea. Asthma can be aggravated. We are seeing patients whose asthma is not controlled with drugs, not controlled with multi-dose inhaler, not controlled with steroid, and if we ask the patient to reduce the weight to some extent, it becomes controlled. So we can link asthma also to obesity. So not only asthma, COPD, not only other dysfunction, but majority of the problem in medicine can be now linked to one and only obesity. So you have to know about obesity in detail. Obesity is multifactorial disease characterized by excessive body fat accumulation that will impair the health, So how you classify obesity? So we Asian have lower cutoff clinically. Why we Asian have lower cutoff clinically? Because it is seen that when the BMI increases, the cardiometabolic risk increases. The cardiometabolic risk of the patient increases. In case of Indian, that cardiometabolic risk increases with lower BMI also. So we Indian cutoffs, we are Asian or Indian have a slightly lower cutoff. What is normal for Indian? 18.5 to 22.9 is normal for Indian. What is overweight for Indian? 22.9 to 24.9 is overweight for Indian, and more than equal to 25 is obese for Indian. So WHO cutoff is slightly different. You can see here WHO obesity is more than equal to 30, but Indian obesity is more than equal to 25. WHO has classified into 3 classes. We are not going to discuss those 3 classes, but for Indian, remember what is obesity is cutoff of more than equal to 25 is obesity. Cutoff for more than equal to 25 is obesity. So obesity can be either generalized obesity, whole of the body structure. There is accumulation of fat in whole of the body structure, in the neck, in the thorax, in the breast tissue, in the abdomen, in the thighs, in the buttocks, in the hip. Everywhere there is accumulation of fat. What is obesity? It's basically the accumulation or the excess accumulation of fat. So it can be everywhere, generalized obesity. Or if you see nowadays, there is increase in case of central obesity or abdominal obesity, where the abdominal viscera accumulate more amount of fat. There is fat accumulation in the abdomen, that is known as central obesity or visceral obesity, and it is a major cardiometabolic risk. And the central obesity, the generalized obesity, so which one has more cardiometabolic risk, whether it is the generalized obesity or the central obesity? Definitely it is the central obesity which has more cardiometabolic risk. What I mean to say, the central obese person are more prone to develop cardiac dysfunction, more prone to develop metabolic dysfunction. So it is more dangerous. The central obesity, the abdominal obesity, visceral obesity is more dangerous than generalized obesity. So how you define central obesity? When you say that the person is having central obesity. Central obesity in India, if we look at a male patient and the waist circumference is more than 90 centimeter, then we say that the patient is having central obesity. And in case of female, if the waist circumference is more than 80 centimeter, then we say that the person is having obesity. So waist circumference, what we are talking about is the waist circumference. More than 90 in male and more than 80 in female is obese, or the patient or the person is having central obesity. We are looking at the waist circumference. But in your clinical exam, in your MD, in your DNB, you will be asked that where we are going to check this waist circumference. Waist circumference. So where we are going to check, or where we are putting our measuring tape, non-stretchable measuring tape, and checking for this waist, whether it is at the level of umbilicus, whether it is level of iliac crest, or where. This is one of the important or the favorite question for examiner in your practical exam, in your clinical exam, that where you are going to look about the waist circumference. So remember, waist circumference we see at a midpoint at midpoint between the costal margin. Say suppose this is the costal margin and this is the iliac crest, the highest part of the iliac crest. So midpoint between the iliac crest and the costal margin, or the tip of the costal margin, last costal margin, tip of the 9 costal cartilage, you draw one line up to the level of the highest level of the iliac crest, and midpoint we put our measuring tape and check the circumference, waist circumference, and if it is more than 90, it is patient is having central obesity. More than 80 in female, having central obesity. It may not correspond at the level of the umbilicus. So don't say your answer that we check waist circumference at the level of the umbilicus, but the correct clinical term is midpoint between the line drawn from the lowest border of the rib up to the iliac crest, midpoint between. This is the waist circumference. So it should be more than 90 in male and more than 18 to say that the patient is having central or visceral obesity. We can also look for the waist hip ratio. Waist divided by hip ratio, and waist divided by hip ratio, if it is in male patient, if it is more than 0.9, if it is more than 0.90, and in female, if the ratio is more than 0.85, then we say that the person is having central obesity. So you know now that where we check for the waist, or where we put our measuring tape for checking the waist circumference. Now tell me where we put our measuring tape to check for the hip. Then only we take out waist by hip ratio. So waist, midpoint between the rib and the iliac crest, last part of the rib and the iliac crest, and hip we check at the level of the greater trochanter. We check at the level of the greater trochanter. We will put one measuring tape at the level of the greater trochanter, and we check for the hip circumference. And waist divided by hip ratio, if it is more than 0.90, if for male, the patient is having visceral obesity or central obesity. For female, if it is more than 0.85. So these are the clinical points you may be asked in your practical exam or clinical exam. So side by side, we are discussing the theory questions. Side by side, we are learning the theory portion of medicine, and side by side the practical portion of medicine. So remember about the central obesity, it is more dangerous than generalized obesity. So what is the pathobiology of obesity? Do you think that the obesity is caused by only one factor, or it is a multifactorial? Obviously, it is a multifactorial. There are some central mechanism playing some role. There are some peripheral mechanism playing some role. So where is the central mechanism, or what control the satiety? What control the appetite when you feel hungry? What control that, okay, now I have eaten enough, now I should stop? So where are those neurons which control the satiety, which control your appetite? It is basically in the hypothalamus. It is basically in your hypothalamus. So a balance is maintained, a homeostasis is maintained by the hypothalamus. The neurohumoral mechanism maintains the balance of your hunger, balance of your satiety, which will ultimately maintain your BMI. So basically a homeostasis or neurohumoral system by hypothalamus maintains your weight or maintains your BMI, maintains your BMI. So if you think that okay, for 1 week I will not eat enough and I will lose my weight, I will lose my weight. So say suppose for 1 week you are eating less and you are losing weight. You have lost 3 kg weight in 1 week. Or say suppose 2 kg weight. You have lost 2 kg by eating less calorie. You have lost 3 kg weight. But the hypothalamus set point always helps, the hypothalamus set point always help or always defend a higher set point, always defend a higher set point. The hypothalamus has its own set point. So if for 1 week you have eaten less and you have lost 2 kg weight, in the next week the hypothalamus will make you more hungry, the hungry signal from the hypothalamus will increase, make you more hungry and decrease your resting energy expenditure, and again you will get weight in the next week. So this is the body's compensatory mechanism so that you do not lose your enough weight, or it is the neurohumoral mechanism which always defend higher set point. Remember, the hypothalamus always defend higher set point. So only by eating less you cannot lose weight. In the next or subsequent week you will again feel more hungry, your resting energy expenditure will decrease, and again energy conservation will occur, and again you will gain more weight, so remember that obesity is not a simple process, it is a multifactorial. There are some hypothalamus appetite regulation done by some nucleus. What are those nucleus? Which control the satiety, which increases the appetite. So these are basically the arcuate nucleus. So arcuate nucleus have orexigenic neuron. So remember, the orexigenic neuron increases the appetite. And what decreases the appetite? The anorexigenic neuron decreases the appetite. So hypothalamus has different neuron which control or which increase the appetite or decrease the appetite to maintain or to defend a higher set point so that you do not lose enough weight. So these are anorexigenic neuron that decreases that appetite, you feel less hungry. And finally this neuron project towards the paraventricular nucleus and lateral hypothalamus. So these are about the central, or in your brain, it is controlled by your brain. But there are some peripheral signal also. The central signal comes from the hypothalamus, the neuron, the orexigenic neuron and the anorexigenic neuron, which increases or decreases the appetite. And the peripheral signal come from the adipose tissue, the pancreas, the stomach, the gut and the small intestine. These also control your weight, body weight, BMI, your hunger, your appetite. So that is why I am saying that the obesity is not a single factor pathology, it is a multifactorial. So adipocyte, if you are having adipose tissue in your body, so normally we have adipose tissue in our body, and excess adipocyte is known as adiposity or obesity. So this adipocyte produce leptin. In a normal individual, normal amount of adipocyte will produce a leptin, and this leptin will decrease the appetite. So if I am having a normal amount of fat or adipose tissue in my body, this normal amount of adipose tissue in my body will produce leptin, and this leptin will decrease my appetite. So normally it will inhibit or will make me not able to eat more food. It will decrease my appetite. But what happens if the person is very much obese, having more amount of adipocyte, more amount of leptin is produced, and the body is now becoming resistant to this leptin. So in obesity, the body become resistant to leptin. So the person or the fat person, although having leptin, more amount of leptin, but now that leptin is resistant, and now that leptin is not suppressing the appetite, so the body become resistant to leptin, and the feedback mechanism is lost. So remember, in obesity there is resistance to leptin. Like diabetes, the patient is having diabetes, there is increased amount of insulin in the early phase, but the patient is becoming resistant to that insulin, blood sugar is not controlled. In the similar way, in obesity there is resistance to leptin, and the weight is not controlled, the person goes on gaining weight. The pancreas secrete insulin in the other way also decreases appetite centrally, but in obesity there is also insulin resistance. So insulin cannot decrease appetite, cannot act centrally and decrease appetite. The stomach secrete ghrelin, which increases the appetite. So remember, these are the hormone implicated in obesity: the leptin, insulin, ghrelin, the GLP-1 analog, and peptide YY. It is produced in the gut, and this is the one hormone which has created revolution in a patient of obesity or in treatment of obesity. This GLP-1 hormone produced by the gastrointestinal tract has made a revolution in medicine in treatment of obesity. These are basically the satiety hormone. And nowadays we are using GLP-1 analog in treatment of obesity. We will discuss later, because it gives a feeling of satiety so that the patient does not eat much, there is calorie deficit, and then there is weight loss, reduction in BMI. But remember, as the hypothalamus set point defends higher set point, then after stopping the drug, most of the time the obesity is reversible, or the obesity comes back again. So but with proper treatment we can reduce the obesity, we can treat the obesity to some extent. We will discuss it in our management section. But GLP-1 and peptide YY are the satiety hormone. Remember, they are the satiety hormone. Cholecystokinin produced from the small intestine leads to contraction of the gallbladder and helps in meal termination, when you should stop eating. The feeling comes from CCK. Adipose tissue as an endocrine organ. So we have discussed already that we have two main type of adipose tissue, white and brown. So everyone knows that the brown adipose tissue help in heat production, thermogenesis, and the white adipose tissue is the storage form of the adipocyte, storage form of the fat cell. Brown thermogenesis, white adipocyte for storage purpose. If we look at the adipokinin and cytokine which is produced, we can see the leptin was produced by the adipocyte. It helps as a satiety signal, but it become resistant in case of obesity. The resistance develop, we have discussed. Adiponectin is a good molecule. The adiponectin is a good molecule. It increases insulin sensitivity. So adiponectin is a good molecule produced in our body which increases insulin sensitivity. So insulin will work better, reduce the blood sugar level, diabetes will not be developed. But what happens in obese person? In obese person, the adiponectin level decreases. The adiponectin is beneficial to us because it increases the insulin sensitivity to the peripheral tissue. The glucose uptake by the peripheral tissue reduce blood glucose level. Diabetes is not developed. But in obese person, the level of the adiponectin decreases. So no adiponectin, No insulin sensitivity, insulin become resistant, patient develop diabetes, vicious cycle of hyperglycemia, obesity, and other cardiometabolic risk continues in the patient. Other cardiometabolic risk will continue in the patient. TNF alpha and interleukin 6 promote inflammation and insulin resistance. So inflammation, whenever we are talking about inflammation, these two molecule or these two compound comes into play, that is the TNF alpha and interleukin 6, so which is more or which increases in case of obesity. So remember, obesity is a chronic low grade inflammation in our body. So if the person is obese, think that in that person, in that patient, there is always chronic low grade inflammation going on in that patient, and chronic low grade inflammation will lead to fatty liver, hepatic steatosis, non-alcoholic fatty liver or non-alcoholic steatohepatitis, NASH, that is hepatitis, inflammation. Patient can have diastolic dysfunction, patient can have obstructive sleep apnea, respiratory dysfunction, kidney dysfunction, metabolic syndrome, diabetes, insulin resistance, and whatnot. The patient, because of low grade inflammation, the patient can develop cardiometabolic dysfunction. So remember that obesity is a chronic state of chronic low grade inflammation, and the patient may develop insulin resistance, diabetes, atherosclerosis, NASH, non-alcoholic steatohepatitis. Resistance or resistin level increases in case of obesity, which may worsen insulin resistance. नाम में ही है resistin. So insulin resistance increases because of resistin, and the patient will develop hyperglycemia. So insulin resistance and metabolic dysfunction. So the patient of obese patient have more visceral fat or generalized fat that will release free fatty acid. Free fatty acid will be transferred to the liver for hepatic lipogenesis, lipid formation, triglyceride formation. So there will be dyslipidemia. The patient will have dyslipidemia. Excess free fatty acid, liver is utilizing fatty acid, so glucose level increases. In order to counteract that, the insulin level increases. The patient will have hyperglycemia because of free fatty acid metabolism in the liver, because of chronic low grade inflammation, because of interleukin 1, TNF alpha. The patient will have steatohepatitis or non-alcoholic fatty liver disease. So in a nutshell, if you say that obesity is a condition in which the patient can develop either NASH, non-alcoholic steatohepatitis, patient can develop diabetes, patient can develop hypertension, patient can develop obstructive sleep apnea, patient can or the severity of the asthma can increase. We have seen patient epigenetic and genetic factor does not play any role in pathogenesis or does not play much role in pathogenesis of obesity, but there are examples where MC4R mutation, LAP and LAPR mutation has been associated with obesity in a patient of twins, So mostly obesity is polygenic but modified by environmental factor. So what environmental factor will modify the obesity? High calorie intake, ultra processed food supply, along with those factors, the hypothalamic factor, the adipocyte, the leptin, the resistin, the adipokinin level decreasing, leptin level increasing but becoming resistant. So these are the factors. Sedentary lifestyle, poor sleep, stress, endocrine dysfunction. The patient is having hypothyroidism, which can lead to obesity. The patient is having metabolic X syndrome, metabolic jet syndrome, obstructive sleep apnea. So in a way of vicious cycle, it will lead to obesity. So it is multifactorial. Obesity is multifactorial. Some drugs like steroid can help patient gain fat in the body, antipsychotic drugs. So basically we can see that obesity is multifactorial. Not only one factor is contributing to become a person obese, but it is multifactorial in origin. And gut microbiome, nowadays the gut microbiota is coming into picture in implication of every disease: the respiratory disease, the central nervous system disease, the gastrointestinal disease, everything. You will see that nowadays extensive research is going on for gut microbiota, and nowadays doctors are linking any dysbiosis in gut microbiota which can produce disease. Dysbiosis in gut microbiota can produce irritable bowel syndrome, associated with some psychiatric condition. So they are talking about gut brain axis. The gut microbiome producing some hormone, producing some substance which is changing the normal mechanism of the brain, so that we are linking gut brain axis in development of some brain disorder, development of some psychiatric disorder. So gut lung axis, we are talking about gut lung axis in development of respiratory pathology, gut axis in development of gastrointestinal pathology. So we can implicate gut microbiota in development of obesity also, because we can see that the altered microbial composition or dysbiosis, which can impact energy harvest, lead to inflammation and insulin resistance. These are the problem with dysbiosis, or dysbiosis means change in the gut microbiota, So what obesity can lead? We have discussed it can lead to hypertension, it can lead to diabetes, hypertension, cardiovascular risk, it can lead to dyslipidemia, naphthalene, obstructive sleep apnea, and asthma. It can lead to asthma also. It can lead to osteoarthritis also. So these are the complication of obesity. It can lead to cancer, it can lead to PCOS, infertility, depression, reduced lifespan. So these are basically the complication of obesity. How do you manage obesity? Do you think that obesity can be managed by only one individual, only the medicine guy? No, obesity, as it is multifactorial, so multi-systemic approach is required. You will require dietitian, you have to control the diet, you will require dietitian, you will require physical trainer, you will require doctors to manage the condition, to issue the hormonal issue, doctor to address the hormonal issue, to address the medication. You will require surgeons. Sometimes the patient may require surgery, like that of bariatric surgery. Basically alteration of gastrointestinal tract to reduce absorption of food and absorption of calorie, that is known as bariatric surgery. This alteration, you make a sleep hole in the stomach, less surface area, less food absorbed, calorie deficit, the patient may be cured of obesity. So it is a multifactorial approach, require medical person, require surgical person, require dietitian, require physical trainer. So because obesity management is multifactorial, change in dietary habit, change in physical activity. We can give drugs, pharmacotherapy, we can use bariatric or metabolic surgery in selected patients. So goal of management, or the scheme of management, can be divided into lifestyle, pharmacotherapy, and bariatric surgery. So lifestyle, we can ask the patient to lose weight. So we can ask the patient to lose weight. How will the patient lose weight? We will say that simply, if you reduce your calorie intake, to around 500 kilocalorie per day. So say suppose the person is taking 2000 kilocalorie per day, then we will ask the patient to reduce his calorie by 500. So 2000, ask him to take 1500 kilocalorie per day. 500 calorie per day should be reduced in that person. This will lead to approximately 1 to 1.5 kg weight loss per week. This will lead to around 1 to 1.5 kg weight loss per week, reduction in calorie reduction. So weight loss helps in improvement of the metabolic health. Weight loss gives major cardiometabolic benefit. The patient will not develop atherosclerotic cardiovascular disease. The patient will not develop NASH. The patient will not develop obstructive sleep apnea. The patient will not develop diabetes. Patient will not develop insulin resistance if we reduce the weight of the person by more than 10 to 15%. So dietary habit, calorie deficit around 500 to 750 kilocalorie per day, approximately 1 kg weight loss per week. 1 kg weight loss per week. Ask the patient how should be the dietary restriction. Ask the patient to take Mediterranean diet. What are the Mediterranean diet? Rich in green vegetables, rich in green vegetables, lean protein, avoid fat. So these are the Mediterranean diet we can advise for our patient. High protein intake, but lean protein, lean meat. Intermittent fasting, although it should not be used as a first resort, or studies have found that intermittent fasting and reducing calorie intake, if you are comparing intermittent fasting with reduced calorie intake, almost same result, same mechanism. So it should not be used as an first resort for treatment of obesity, intermittent fasting. But the main you can advise or we can advise is the calorie restriction, 500 to 750 kilocalorie per day restriction, which can lead to approximately 1 kg weight loss per week. 1 kg weight loss per week. Avoid sugary food, adequate protein, whole food emphasis, and long-term adherence is more important than diet type. So these are the important points. Physical activity, we ask the patient after diet. Next, we ask the patient to do physical activity. How much of physical activity? Around 30 to 60 minutes exercise. Say suppose brisk walking. Simple walking will not help. ब्रिस्क वॉकिंग, इसे जोर जोर से चलना पड़ेगा, धीरे धीरे चलने से कुछ नहीं होगा. तो ब्रिस्क वॉकिंग 30 to 60 मिनट पर डे, 5 days a week. हफ्ते में 5 दिन चलने से भी होगा, जोर जोर से चलना पड़ेगा. 30 to 60 minute per day, which will be approximately 150 to 300 minutes per week. Moderate exercise. Remember, moderate exercise. Simple walking will not help. Either running or either brisk walking. जल्दी जल्दी चलना पड़ेगा. 150 to 300. Resistance training can help, improves insulin sensitivity and weight maintenance, even if modest weight loss. So physical activity helps in this thing. Behavioral therapy. So what about weight loss? Weight loss, how much weight loss you can expect in that patient? So remember, around 5 to 10% of the body weight can be lost in around 3 to 6 month period. So in 3 to 6 month period, we can allow around 5 to 10% of the weight loss in the patient. Remember, so say suppose if the patient is having 100 kg, we can allow 10 kg weight loss in period of 3 to 6 months. Excessive fat loss or rapid fat loss is not advocated in the patient. It can lead to complication. So monitor weight over a period of 3 to 6 months. Allow him to lose weight for around 5 to 10%, maximum up to 15% in some cases. Behavior therapy, self-monitoring, goal setting, problem solving, sleep optimization, stress management, motivational interview and structure program shows highest success. So losing weight is easy, but maintaining that weight is more difficult. Pharmacotherapy. Who are the person or who are the patient in which we will start pharmacotherapy in which we will start drug. BMI of more than 30, that is the WHO cutoff. But for Indian, BMI of 27.5, if it is more than 27.5, then we should start the patient with drugs that will reduce the weight of the patient. And if the BMI is more than 25 in Indian, plus the patient is having comorbidity. Say the patient is having obstructive sleep apnea, the patient is having NASH, the patient is having atherosclerotic cardiovascular disease, the patient is going to develop, means patient is having cardiometabolic risk factor, comorbidity, diabetes, patient is having diabetes, obstructive sleep apnea, and BMI is more than 25, then we can use drug to reduce the weight. To treat the obesity, we can use drug. What are the drug we will define? So remember, the Indian cutoff are slightly low. If it is more than 27.5, if we use drug, and if it is more than 25 plus the patient is having comorbidity, we use drug. For Indian guideline, for WHO, these are the guideline or worldwide guideline. So currently, what are the agent we use for treatment of obesity? We have discussed that GLP analog. These are creating a revolution in treatment of obesity. These are the semaglutide. That semaglutide 2.4 mg weekly we can give, as we know that it increases satiety, the patient will eat less calorie, so weight reduction. So typical weight loss 10 to 15%, semaglutide, satiety, delayed gastric emptying, the patient feel fullness, not able to eat, so weight loss. We can use dual GLP and GIP analog like tirzepatide 2.5 mg weekly, increase maximum up to 15 mg, start at 2.5 mg weekly, increase up to maximum of 15 mg. But remember, it is contraindicated in patient with medullary carcinoma of the thyroid or Mann syndrome. So studies have seen that it can cause medullary carcinoma of the thyroid. So the patient is having history of medullary carcinoma of the thyroid, then this drug tirzepatide is contraindicated. The dose of tirzepatide is 2.5 mg subcut weekly, increase up to 15. Maximum patient respond at around 10 to 15 mg subcut weekly. So it has dual action, GLP, GIP analog. More than 15 to 20% weight reduction is seen. Liraglutide can be used, orlistat can be used. So the newer drug are mainly the semaglutide and tirzepatide. So orlistat can have more side effect, bloating sensation, fat malabsorption, fat vitamin, which are fat soluble vitamin, patient can have malabsorption because of use of orlistat. So nowadays it has rarely being used. Bupropion, naltrexone, appetite reduction can be used, supportive treatment. Phentermine, topiramate can be used, also causes satiety. So every patient has to be individualized. Nowadays it is an era of individual treatment of the patient. We are not treating patient of asthma. All patients of asthma are not same. We are not treating all patients of COPD with the same medication. We are individualizing the treatment. Asthma, there are type 1 asthma, high asthma, low asthma, COPD patient with eosinophilia, without eosinophilia. So we are going into era of individual treatment or personalized medicine. In the similar way, treatment of obesity should also be personalized. So we should assess the contraindication of every individual, and the treatment should be personalized. Today is the era of personalized medication. And remember that the medication are long-term therapy. Stopping often lead to regain. What I told you, the main problem is the hypothalamus always trying to defend high set point, but we combine diet, physical activity, drugs in some case. Last resort is the bariatric surgery, and try to maintain the weight of the patient. Try to maintain the weight of the patient. Who are the patients who are subjected to bariatric surgery? Very high BMI, more than 40. BMI more than 35 with comorbidities like hypertension, diabetes, obstructive sleep apnea. BMI more than 30 with uncontrolled diabetes. In selected case, we can go for bariatric surgery. Procedure like sleep gastrectomy, Row and Y gastric bypass, and one anastomosis gastric bypass. These are the surgery which decreases the surface area for absorption and lead to reduced calorie absorption, and which can lead to weight loss in the patient. Benefit of bariatric surgery are very high. The patient always lost weight. Remember, Ranbir Kapoor lost weight with bariatric surgery. I am not sure, but I have heard. So benefit, 25 to 35% durable weight loss can be achieved with bariatric surgery. Diabetes remission in many patients, but it decreases cardiovascular mortality and decreases NAFLD. Nowadays, NAFLD is known as muscle metabolic dysfunction associated liver disease. So the progression requires lifelong nutritional monitoring. The patient can develop vitamin deficiency. Patient can develop some specific deficiency because of surgery. So manage comorbidity, manage diabetes, hypertension, dyslipidemia, obstructive sleep apnea, whatever that is associated with obesity. Vaccination, contraception, counseling, and pregnancy planning are important. Pregnancy planning is more important. The patient can develop eclampsia, preeclampsia, obese patient. Psychosocial stigma and relapse prevention. Obesity stigma worsen outcome. So मेरा बच्चा तो बहुत हेल्दी है, मोटा है, हेल्दी नहीं है वो. So that if the patient or if the parents think that their child is healthy, if their child is obese, this is a misconception. Nowadays, childhood obesity are also increasing too much, which will progress to adult obesity and finally the cardiometabolic risk. So remember to address the stigma also. Relapse is common, follow-up is essential. Chronic care model recommended. So the patient will require long-term monitoring and treatment. So to conclude about the obesity, obesity is a neuroendocrine metabolic inflammatory stage driven by some genetic susceptible factor and obesogenic environment, sedentary lifestyle, fatty food, processed food, comprehensive management combining lifestyle, diet, exercise, pharmacological agent, and bariatric surgery only when indicated produce the best outcome with sustained follow-up crucial long-term success. So remember that we do not start drugs for all the patient. First, we will go for diet, Mediterranean diet plus physical activity. So with diet and physical activity for some months, say suppose 3 to 6 months, if it is not controlled, still the BMI is more than 27.5 or more than 25 plus comorbidity, we can use pharmacotherapy in the patient. But if BMI is more than 30, then we can use or we can go for bariatric surgery if not controlled with drugs. But first we will try diet, physical activity. If the obesity or the BMI cannot be controlled with diet and physical activity, then we can go for drugs. Remember to use personalized medicine in case of obesity, and remember that obesity can recur or it can relapse if the dietary and physical activity habits are not followed, if the calorie restriction is not followed because of the defending capacity of the higher set point of the hypothalamus.